To assist the examination, you must place your examination of heart and great vessels in the context of the patient health history and also understand the anatomy of heart and the vascular structures of the neck and the chest. Now to begin with the examination of the jugular venous pulsations, adjust the head of the examination table to the 30 degrees. With the patient supine, place the patient head on a pillow just to the top of the shoulder to relax the sternomastoid muscle. Examine both sides of the neck, then turn the patient head slightly to the left. Since the physical examination is conducted from the patient's right side, identify the external jugular vein, then find the internal jugular venous pulsations. Now look for the oscillation point on the sternomastoid between the clavicle and the angle of jaw or just posterior to the sternomastoid muscle. To measure the oscillation point of pulsation in the right internal jugular vein using the following technique. Extend an elongated rectangular object such as a 3x5 card from the meniscus point of pulsation while extending a centimeter ruler vertically from the sternal angle, making a right angle. To establish the true vertical and horizontal lines, place your ruler on the sternal angle and line it up with the vertical line in the room. Then place your card on the other rectangular object to an exact angle of the ruler. Make sure one edge of the card is at the point of oscillation of the jugular venous pulsation. To keep the card horizontal, read the vertical distance where the card crosses the ruler. This measurement identifies the jugular venous pressure, the vertical distance in the centimeter above the sternal angle where your card crosses the ruler. Round your measurement to the nearest centimeter. In this patient, the jugular venous pressure is about 3 cm above the sternal angle. Now we are assessing the carotid pulse. Carotid pulse provide valuable information about valvular heart disease and especially useful for detecting aortic stenosis and aortic insufficiency. Inspect and palpate both right and left carotid artery, then compare. However, do not press at both carotid arteries at once, since syncope may occur. And place your index and middle fingers on the right carotid arteries on the right third of the neck and slowly increase the pressure until you feel the maximum pulsations, then slowly decrease the pressure until you best sense the arterial pressure wave. Try to assess the amplitude of the pulse. This correlates reasonably well with the pulse pressure. This illustration represents the contour of the pulse wave, that is the speed of the upstroke, the duration of its summit and the downstroke. The normal upstroke is brisk, smooth and rapid and follow S1 immediately. The summit is smooth rounded and roughly mid-systolic. The downstroke is less abrupt than upstroke. Anatomy review of the heart. Right atrium from the right border of the heart and left atrium is mostly posterior, neither the right nor the left atrium, and can be examined directly above the heart. And like great vessels, the pulmonary artery arises from the right atrium and quickly bifurcates into the right and left branches. The aorta arises from the left ventricle. Most of the anterior surface of the heart is made up of the right ventricle. The left ventricle lies to the left and behind the right ventricle. It forms the left border of the heart and produces the apical impulse. Examination of heart by inspection, palpation and auscultation. Begin with the inspection and palpation. Have the patient remain supine with the upper body raised to the 30 degrees. First, inspect the anterior chest, noting any heaves and lifts. None are observed here. Careful inspection may also reveal the location of the apical impulse. Later in the examination, clearly identify the apical impulse. Now proceed with the palpating the chest wall. Palpate the right and left second interspaces along with the left sternal border in the apical area. Then check for the thrills by pressing the ball of your hand firmly on the chest in these same locations. Then using the palmar surface of several fingers for finer assessments, your fingertips followed by one finger alone palpate to confirm the characteristics of the apical impulses. You will know its location, diameter and amplitude. If you experience difficulty in locating apical impulse, ask the patient to partially roll on its left lateral side, that is the left lateral decubitus position. Now palpate again by using the palmar surfaces of several fingers. Measure the diameter of the impulse in centimeters. Feel for the amplitude of the apical impulse. Next, feel for the right ventricular impulse at the lower left sternal border while keeping third finger in the third interspace and additional fingertips in the fourth and the fifth interspace. Then feel for the right ventricular impulse in the epigastric and subxiphoid area and ask the patient to take breath in. Now, auscultation of the heart sound is important skill that leads directly to important clinical diagnosis before auscultating the heart. When auscultating, it's important to know your stethoscope. The diaphragm is better for detecting higher pitch sounds such as S1 and S2. To begin the auscultation sequence, adjust the stethoscope so that you listen through the diaphragm. Begin listen in the aortic area in the right second interspace. Now switch the bell of the stethoscope. Listen next along the lower left sternal border in the left fourth and fifth interspaces. Then listen the apex. To improve your ability to hear S3, S4 and the murmurs of the mitral stenosis, ask the patient to move in the left, that is the lateral decubitus position. This brings the left ventricle closer to the chest wall and makes low pitch sound more audible.